What we demonstrated is a new concept. This new concept is based not only on limiting progression, but on trying to improve disability in patients with progressive disease. So we tested this molecule in a particular patients that had a primary or secondary progressive multiple sclerosis with a disabling disease, and these patients were worsening in the past 2 years. What we thought is that maybe we could try to demonstrate that we may improve these patients, not only limit their progression. And so this randomized trial that was evaluating this drug against placebo demonstrated that we may improve a certain proportion of patients in a way, and in the other way decrease the percentage of patients that were progressing. And we can say globally in this trial that the patients that improved were more important than patients that progressed under this treatment, which is the first time that such a drug gave this kind of results. We presented the first trial, which is called MS-SPY trial. We're expecting the results for MS-ON trial, which are patients with optic neuritis. And we are thinking if it's necessary to do a third trial, which is a very large scale trial with more patients for more time, and which would be independent and maybe more international with other countries to confirm the first results. And it's probably also interesting in other metabolic diseases like adrenomyeloneuropathy or other diseases like this, where spinal cord is injured and axons are involved. And if this works in this kind of pathology of diseases, then this should be really very promising. For sure, these results have to be confirmed. We have to wait for the extension phase, where all patients, placebo included, are under treatment to see if the effect is persisting, and to see in the other way if patients that were under placebo reversed their worsening curve. If we have these results, then I think that this should be very promising for treating patients. And the other thing that is promising is that this drug can be combined to other drugs. And this is nice because if we think that we could use very strong anti-inflammatory treatments and add neuroprotective treatment, then this combination, if it's safe, and this seems to be the case, then this is very promising for, in a way, decreasing at the most inflammation, and in the other way protecting neurons and enhancing and promoting remyelination. For the same concept, for the moment we don't have treatments. There were some trials. The first one with, for example, the fingolimod, which is already used in the relapsing remitting phase of the disease, that was tried in the primary progressive phenotype, and the results of the trial, which is called the INFORM trial, were negative. So for the moment, this is a little bit, I would say, frustrating, because it was promising, but the results are negative, and this is not good for patients, because what we want is that patients had the most reasonable treatments for this. There are other molecules that are lipids, like olixozyme, and these has been tried in the phase 1 for the tolerance, and it seems to be very well tolerated with a very nice safety profile. And now this needs more development in another phase, phase 2 and then phase 3 possibly, to see if we could go until repair. There is the anti-lingo, and the results were presented at the AAN at the same session, at the same Congress meeting where the Biotin results were presented. And these results show that after 6 months of using of this antibody, there were some results only in per protocol analysis, not in intention to treat analysis, probably promising for restoring the electrophysiology of optic nerve conduction. But we still need to wait for confirmatory results with this kind of drugs. So there are a lot of drugs that are coming, and I think that maybe in the 5 coming years we'll have nice perspectives for treating this particular aspect of the disease. From here, I think that it's very important to continue to develop this kind of strategies and to demonstrate that we can combine all these, because the target is not the same. And what is important in multiple sclerosis is that there is no one single pathophysiology. You have a lot of targets that are fluctuating over time with the changing of the aspect of the disease, and it's very important to demonstrate with our researchers that this one kind of drug is important at a phase of the disease and another at another phase.